Now, I have covered the two topics which were mentioned in the group, and now I am going to cover a very high yield topics that you must get on your USMLE. I have seen that topic of interstitial nephritis, tubular acidosis, and the of you must get from, like, there are the pet topics like in nephrotic syndrome. You would say that type of acidosis, interstitial, and the kidney stones, you must get MCQ. So moving toward the high yield, what will happen into the renal tubular acidosis? There is the slotting of the proximal convoluted tubular cells due to either the chemical or the ischemic insult. So the most of 50% of the question will mention that the patient have muddy brown granular cast. Always remember, whenever there is a muddy brown granular cast, always go for tubular acidosis. And the 50% of the question will mention that oligouria or acutely worsening function. Now, there are the three main causes of the acute renal tubular acidosis. First of all is the drugs aminoglycosides. Now, there are the certain drugs that are associated with certain specific pathology. So you have to remember these drugs on the fingertips. Like whenever the drug of aminoglycoside is there, without confusing with interstitial nephritis, papillary necrosis, always go for tubular acidosis because aminoglycoside is specific for tubular acidosis. Gentamicin, tobramycin, amikacin, cisplatin, or the IV contrast. These are very three high-yield drugs. So whenever the Bignett will give you any of the above drug like gentamicin and will say the new onset oligouria and the creatinine, even they will no mention the cause. I would say either they will mention the granular cause, that is a one buzzword, and otherwise they will give the specific drug that leads to tubular acidosis, that are the three drugs. So whatsoever, either you get that buzzword or you get that buzzword, always go or answer of the acute tubular necrosis. And the patient who is the recently been treated for endocarditis and has now new onset oligouria. So the answer will be the acute tubular necrosis due to the gentamicin. That is the one cause of, we have another causes too, like the cause of the rhabdomyolysis and acute ischemia also results in the tubular necrosis. So how is that? We know that myoglobin is a nephrotoxic. And the biggest risk factors are alcoholism, even the fall, you get muscle traumas, intense training, and even the statin and your fibrates, which also results in the myopathy and rhabdomyolysis. So, rhabdomyolysis causes a false blood on urine dipstick. That is a very high yield point. On MBME, there is a question, and that Vignette is the patient is being found at the bottom of the stairs. So, you know that it's the history of trauma. Now has the false positive blood. I know that false positive blood is due to the rhabdomyolysis and the oligouria. So the locate out the buzzword. They will never simply mention the rhabdomyolysis. You have to pick out that it's the case of the trauma, it's the positive blood and oligouria. We have only condition that is that rhabdomyolysis, and rhabdomyolysis results in acute tubular necrosis. That's why this patient is getting the sign of oligouria. Must remember that is a very high yield point. And last one is that acute ischemia. And I have seen most of the time when they are like checking the concept of acute tubular necrosis, they will mention that cause, acute ischemia. It is the highest yield cause, even on MBMEs. You know that the proximal convoluted tubule of the kidney is more susceptible to the anoxic and hypoxic injury. This is due to the concentration of proximal convoluted tubule have ATPs transported. So whenever there is a sudden acute drop in the blood flow, an acute hypoxia results in the proximal convoluted tubule shutting down. These shutting down when get into your tubules and that necrosis results in that condition. So Vignit will mention a woman had the surgery and 30-second episode. Always remember acute tubular acidosis, acute, their ischemia is of acute nature, not chronic nature. Suddenly, BP fell down to the 80 and 40. So always remember the condition here is acute tubular necrosis, not prerenal. Whenever the case is of acute like that 30-second, always go for acute tubular necrosis. Even I have seen another witness too, that RTA and the patient present in the like ER and however has an oligouria. So always remember that in RTA there is also loss of blood. So that loss of the blood damages your proximal convoluted tubule, that acute ischemia and results in acute tubular necrosis. So acute ischemia either related to your surgery, hospital condition, and either your like accident condition, and patient gets symptoms of oligouria, always go for acute tubular necrosis. And another, always remember these three drugs too.